Hello, everyone, and welcome to INICET revision. INICET revision for the coming exam in November. Now, we are going to discuss a number of important topics as far as physiology is concerned, right? And let's start. Let's start. Now, this is a hot topic. I expect a question from the receptors. We definitely expect that there is going to be a topic from the receptors. A hot topic. I expect. So let's have a quick revision of what are these meant for. Let's see the somatic receptors. Basilian corpuscle. Basilian corpuscle is a very rapidly adapting touch receptor, and this is meant for fast vibration. This is specifically meant, it's a very rapidly adapting touch receptor which is meant for fast vibration up to 800 cycles per second. Even though it is a very rapidly adapting touch receptor, but this is specific for fast vibration. This is also meant for deep pressure such as poking. Deep pressure such as poking. Meissner's corpuscle. Now, Meissner's corpuscle has been asked as a question in the recent INICET exam. Now, Meissner's corpuscle is again a rapidly adapting touch receptor, and Meissner's corpuscle is meant for fine, well-localized touch. And when I talk in terms of fine, well-localized touch, this is also known as discriminative touch. This is fine, well-localized touch, and like I said, this is also known as discriminative touch. The Meissner's corpuscle is also meant for slow vibration up to 80 cycles per second. It is also meant for texture. It is also meant for topognosis. Topognosis is whenever you want to feel a surface, you use your fingertips to feel a surface, or for texture of any material. The reason is because the fingertips have got plenty of Meissner's corpuscles. In fact, 60% of the sensory input from the fingertips is from the Meissner's corpuscles. So these Meissner's corpuscles are for fine, well-localized touch or discriminative touch, also for slow vibration, for texture, for topognosis. There was a question which was asked earlier on Braille. Braille is a script for the visually challenged. They read, there's a special script which has got elevations and depressions, and they use their fingertips and trace those elevations and depressions on that paper, and that's how they read. So again, they are using their Meissner's corpuscles while reading that script, Braille. Now, also hair end organs. Hair end organs are associated with the hair end organs. Like I said, these are associated with hair follicles, and they're meant for light movement on the skin. These are also very rapidly adapting touch receptors. Merkel's discs. Now, Merkel's discs and Meissner's corpuscles have overlapping functions. Merkel's disc is also meant for fine, well-localized touch, for discriminative touch. But if you get a question on discriminative touch, please go for Meissner's corpuscles rather than Merkel's discs. Merkel's discs are more superficial. They are located in the epidermis, whereas Meissner's are in the dermal pegs. Merkel's discs also can detect sustained pressure. Ruffini's endings, again, fine, well-localized touch, but also prolonged pressure. They can also detect stretch, and to some extent, vibration. C mechanoreceptors, these are meant for crude touch and for pressure, right? Crude touch and pressure. So these are some important mechanoreceptors which are located in the skin, which I needed to talk about. And again, a little diagrammatic representation of the location of these different receptors. We've got hairy skin and glabrous skin over here. Meissner's corpuscles are elongated, encapsulated receptors which are present in the dermal pegs, right? And especially where in glabrous skin. Glabrous skin is non-hairy skin, like that, the skin of the palms and the soles, and they're especially abundant on fingertips, lips, nipples. These are the areas where you have Meissner's corpuscles. And I've already told you Meissner's corpuscles for fine, well-localized touch or discriminated touch, for slow vibration, for texture, for topognosis, and for braille. Merkel's discs are more superficial in location. They are located in the epidermis. Merkel's discs are located in both the hairy as well as glabrous skin, and again I said they have overlapping functions with the Meissner's corpuscles, but Merkel's discs are relatively slowly adapting as compared to Meissner's corpuscles. So Merkel's discs can also detect sustained pressure. Ruffini's endings are also located in hairy and glabrous skin, but they are located in the dermis. And Ruffini's endings, again, fine, well localized touch, prolonged pressure for stretch, and to some extent also vibration. Pacinian corpuscle. Now, Pacinian corpuscle is it's much more deep location, deep in the fasciae, in the muscles, deep in the skin. This is where you get the Pacinian corpuscle. So Pacinian corpuscle is meant for deep pressure poking. Pacinian corpuscles are abundant in joint capsules, and the Pacinian corpuscles, like I told you, they are very rapidly adapting touch receptor, but are specific for fast vibration, up to 800 cycles per second. Now, TRP channels. Now, this is again going to be this is an expected question again, because of the fact that the Nobel Prize in Physiology and Medicine has been given to two researchers who have worked on TRP channels, and that is David Julius and Ardem Pataputian. So these TRP channels, these are transient receptor potential channels, and these are a family of excitatory channels, and they have a number of subfamilies. There are vanilloid receptors. There are ankyrin receptors, vanilloid receptors, ankyrin receptors. Vanilloid receptors, ankyrin receptors. You have the vanilloid receptors, ankyrin receptors, acid sensing ion channels. Then you also have what are known as purinergic receptors. Purinergic receptors, these are subfamilies of the TRP channels. Purinergic receptors, and number 5, you also have menthol receptors. Now, a little bit more, and especially work has been done. David Julius worked on vanilloid receptors, and Ardem Pataputian has worked on menthol receptors and on piezo 1 and piezo 2. This is the work which has been done by David Julius and by Ardem Pataputian. Now, what are these vanilloid receptors meant for? TRPV1 receptor. This is meant to detect H+, chemicals, especially capsaicin. Then for detecting warmth, you have TRPV3 and TRPV4. This is meant for heat. These are meant for heat. And ankyrin receptors, TRPA1. This is meant for pain. Acid sensing ion channel, it is meant for the detection of H+. Purinergic receptors are P2X and P2Y. P2X and P2Y, and these again detect mechanical pain. Menthol receptors, TRPM8. This is meant for menthol as well as for moderate cold. Piezo 1 and piezo 2 are receptors which are involved in proprioception. Right? So this is as far as your these different TRP channels are concerned. What are these TRP channels? Like I said, these are transient receptor potential channels. These are a family of excitatory channels, and these are family of excitatory channels. Family of excitatory channels with a number of subfamilies: vanilloid receptors, N-chirin receptors, acid-sensing ion channels, purinergic receptors, menthol receptors, piezo 1, piezo 2. Right. Let's go on to another topic which we expect questions from, and that is the action potential. Favorite topic as far as INICET is concerned. What are the phases of action potential? What are the reasons for the action potential? Now, resting membrane potential in most neurons is minus 70 millivolts. Now, when a stimulus is given, there is going to be opening of voltage-gated sodium channels. There is influx of sodium. The potential of the cell will become less negative, and the moment it reaches minus 55 millivolts, which is minus 55 millivolts is the firing level or the threshold potential. Once it reaches minus 55, then the opening of sodium channels is by a positive feedback mechanism. So there is going to be the depolarization phase where the potential touches 0 and goes right up to plus 30 millivolts. This is known as the depolarization phase, which is due to opening of the fast voltage gated sodium channels. Then the repolarization phase, which is because of closure of sodium and opening of potassium. Closure of sodium and opening of potassium. And then you have a after depolarization phase, which is because there is a decrease in the rate of potassium efflux during this phase. And the last phase is the hyperpolarization phase, which is due to a slow closure of the potassium channels. So there is some potassium efflux which continues in this phase, and the potential now becomes 1 to 2 millivolts more negative than the resting membrane potential. Right, so this is as far as the phases of action potential. Important point, please remember, in the repolarization phase, what is the repolarization phase due to? Closure of sodium and opening of the potassium channels. Right? And opening of the potassium channels. And remember, when I say closure of the sodium channels have got two gates, activation gate and an inactivation gate. The first gate to close is the inactivation gate. So sodium channels are fast channels, fast to open, fast to close, but which is the first gate which closes is the inactivation gate. And where is the inactivation gate? It is towards the inside of the cell membrane. So inactivation gate is the first one to close. This is an important from INICET point of view. This is what are the changes in ion permeability or the changes in membrane conductance of sodium and potassium during different phases of the action potential. So if you can see this over here, on the y-axis, now here we have membrane potential. So this is for the action potential. On the right side, you've got how many channels, open channels per square micrometer of membrane. This is basically trying to tell you how many channels are open for sodium and how many are open for potassium at a given point in the action potential. Basically, we are trying to see what are the changes in ion permeability during different phases of the action potential, and how do we correlate it with different phases in action potential. Now, for example, when you give a stimulus, first there is a sharp increase in the membrane permeability for sodium. Why so? Because now when you give a stimulus, there is opening of voltage-gated sodium channels. So that increases the membrane permeability for sodium. So there is a sharp increase in the membrane permeability for sodium, which is responsible for the depolarization phase. Then the fast sodium channels close. So there is going to be now a decrease in the membrane permeability for sodium, and simultaneously there is the opening of the slow voltage-gated potassium channels. As you can see it over here, there is going to be an increase in potassium conductance. So I told you the depolarization phase is due to increase in the sodium influx, and the repolarization phase is due to decrease in sodium influx, closure of the sodium channels, plus an increase in the potassium efflux, right? So this is again an important graph that we have to do, that we have to understand what are the changes in the membrane conductance for sodium and potassium during different phases of the action potential. If you can see this, just after the peak of the sodium conductance, this is the peak of the sodium conductance is followed by the peak of the action potential as well. Then the repolarization phase due to closure of sodium and opening of potassium, right? And we can see this. What is this hyperpolarization phase due to? It is due to a slow decrease in potassium conductance, or a slow closure of the potassium channels, right? So this is as far as the changes in ion permeability during different phases of the action potential. Another important graph as far as the INICET preparation is concerned, and that is the length tension relationship. This has been asked in different forms, different forms. In different forms in the last 2 years. Length tension relationship: more the initial length, more will be the tension generated, but up to a physiological limit, beyond which further increase in initial length will decrease the tension generated. And this is your Frank-Starling's law, right? This is your Frank-Starling's law, right? More the initial length, more is the tension generated up to a physiological limit. And we apply this to the ventricular muscle, isn't it? We said that more the initial length of the ventricular muscle, more will be the tension generated. How can the initial length of the ventricular muscle fiber increase? When there is increase in the end diastolic volume. More the filling of the ventricle, more will be the end diastolic volume, more will be the initial length of the ventricular muscle fiber, more will be the tension generated, but up to a physiological limit, right? Now, the important point which I want you to focus on over here is, when you look at, we are what is given on the y-axis is the tension as a percentage of maximum. This is where you've got 100% tension. That means maximum tension. The corresponding length where you get maximum tension, that is known as the optimum length. Optimum length, or it is also called the resting length, right? It's called the optimum length, or it's called the resting length. Important point, right? And this resting length, it corresponds to a sarcomere length of. This resting length, it will correspond to a sarcomere length of 2 to 2.2 microns. And at this length of the sarcomere, you have a maximum overlap between actin and myosin. You have maximum number of actin-myosin cross bridges and maximum tension generated. So this is, so please remember, optimal length is known as the resting length. Initial length is not known as the resting length. It is the optimum length, which is known as the resting length. Now, neuromuscular junction, again, a favorite topic as far as INICET is concerned. Now, neuromuscular junction, you have on the presynaptic membrane, you've got voltage-gated calcium channels. So as soon as action potential reaches over here, there is influx of calcium through these voltage-gated calcium channels. Docking proteins are already present in the A-alpha motor neuron, and with calcium also entering into the cell, there is now going to be exocytosis of acetylcholine. And acetylcholine will diffuse across the synaptic cleft and bind with the acetylcholine receptors. Acetylcholine receptors. Now, 2-3 important points. Number one, acetylcholine receptors, what are these? Are these voltage-gated? Are these ligand-gated channels? Now, these are ligand-gated. Are these sodium channels or are these potassium channels? These are ligand-gated sodium and potassium channels. These are ligand-gated sodium and potassium channels. But the point is that the movement of sodium predominates through these channels. Movement of sodium predominates through these channels. So a lot of time we remember them as ligand-gated sodium channels, but in fact they are ligand-gated sodium and potassium channels. Second important point, the acetylcholine, when it binds with acetylcholine receptors on the motor end plate, it cannot generate an action potential here. It generates a local potential which is known as the motor end plate potential. So if you're asked a question, motor end plate potential is generated by voltage gated sodium channels or ligand gated channels. It is ligand gated channels, and these are limited to the motor end plate. Now, these local potentials which are generated at the motor end plate, they will summate, and an action potential will be generated which now travels all over the muscle fiber membrane. So this propagated action potential which is generated over the muscle fiber membrane other than the motor end plate, this is via voltage gated sodium and potassium channels. So please understand, the ligand gated sodium and potassium channels, they are limited to the motor end plate. Remaining part of the muscle fiber membrane has got the voltage gated sodium and potassium channels, and the action potential will spread all over the muscle fiber membrane via these channels. Now, a next important point, which are the docking proteins which are present in the motor neuron? The docking proteins are syntaxin, synaptobrevin, and SNAP25. These are the docking proteins which are present, and these docking proteins are affected by botulinum toxin. Botulinum toxin will act on these docking proteins and inhibit these docking proteins. But the botulinum toxin, you've got different types of botulinum toxin: A, B, C, D, E, F, G. In fact, C is C1 and C2. So there are these 8 types of botulinum toxin. But what toxic to humans are A, B, and E. These are toxic to humans. A and E will affect the SNAP25, and B affects synaptobrevin. So please remember that B will affect synaptobrevin. So obviously, botulinum toxin will act on the neuromuscular junction. If these docking proteins are inactivated, there is going to be no release of acetylcholine, flaccid paralysis. Tetanus toxin also affects the docking proteins. Tetanus toxin affects synaptobrevin, but not at the neuromuscular junction. Tetanus toxin inhibits synaptobrevin in the spinal cord, where it inhibits the release of inhibitory neurotransmitters, that is glycine and GABA, and it gives rise to a spastic paralysis. A disease of the presynaptic membrane where antibodies are against voltage-gated calcium channels, Lambert-Eaton syndrome. A disease of the postsynaptic membrane where antibodies are against the acetylcholine receptors, myasthenia gravis. Lambert-Eaton syndrome, the weakness will improve as the day progresses, and in myasthenia gravis, weakness will worsen as the day progresses. In Lambert-Eaton syndrome, why does the weakness improve as the day progresses? This is because repeated stimulation will cause an accumulation of calcium. In the acetylcholine receptor, in myasthenia gravis, the weakness will worsen as the day progresses. This is because repeated stimulation will produce exhaustion of the neurotransmitter. Next, let's see renal clearance. Now, this is an interesting graph, again, which we should be absolutely clear about. When we look at clearance, what is the definition of clearance? Clearance is clearance of any substance X. Clearance is the volume of plasma free of that substance in unit time. So, clearance of X will be UV by P. It is urinary concentration of X into V divided by plasma concentration of X. Urinary concentration of X can be in milligram per ml. V is rate of urine flow, which is in ml per minute. Plasma concentration is also in milligram per ml. These two will cancel each other out, and clearance will be in ml per minute. Again, what is clearance? Volume of plasma free of that substance in unit time. So since it's volume of plasma free of that substance in unit time, so the unit is going to be ml per minute. What is the formula for clearance? UV by P. What is U? urinary concentration of X in milligram per ml. What is V? This is the rate of urine flow, which is in ml per minute. What is Px? This is the plasma concentration of X in milligram per ml. Both of these will cancel each other out, milligram per ml, and the unit for clearance will be in ml per minute. Now, if you look at this over here, now clearance of inulin. Inulin is a substance which is freely filtered, not reabsorbed, not secreted. So clearance of inulin is taken as equal to GFR, and this is C, right? This is the clearance of inulin equal to GFR. Any substance which is reabsorbed will have a clearance less than the clearance of inulin. So all reabsorbed substances will have a clearance less than the clearance of inulin. See, why do I say reabsorbed substances will have a clearance less than the clearance of inulin? Because reabsorption means that the substance is re-entering into the plasma. So volume of plasma free of that substance in unit time will now reduce. On the other hand, substances which are going to be secreted will have a clearance which is more than the clearance of inulin. That means secretion means the substance comes from the plasma into the urine. So the volume of plasma free of that substance in unit time will now increase, right? So if you look at D is probably the clearance of glucose. Why do I call it the clearance of glucose? Because you can see below a certain plasma concentration, the clearance of glucose is 0, which is true, isn't it? Below renal threshold, there is urinary glucose is 0. So what is the formula for clearance? Clearance is UV by P. If urinary concentration is 0, clearance will also be 0. So below renal threshold, the clearance of glucose is 0. It's after it crosses renal threshold that the clearance of glucose will begin to increase, but it's less than the clearance of inulin. What is B here? B here is the clearance of creatinine. Why? Because creatinine is freely filtered and slightly secreted. So the clearance of creatinine is slightly more than the clearance of inulin. And what is A? Now, A is a substance which has a very high clearance, at least in low concentration. And this is going to be the clearance of para-aminohippuric acid, which in low concentration is equal to renal plasma flow. Right? In low concentration, very high clearance for para-aminohippuric acid, but as the concentration increases, the clearance of para-aminohippuric acid reduces. Yes? Now, para-aminohippuric acid is a substance which is freely filtered and completely secreted in low concentration. But in high concentration, incomplete secretion. And because it has an incomplete secretion in high concentration, therefore the clearance of para-aminohippuric acid decreases at high concentration. Clearance of para-aminohippuric acid in low concentration is equal to renal plasma flow. So this is again an important graph which I wanted you to understand. That is on the clearance. Now a little more detail about how is sodium reabsorbed in the thick ascending limb. A lot of questions have been asked from there. How is sodium absorbed in the thick ascending limb? So if I look at the sodium reabsorption in the thick ascending limb, the mechanism for sodium reabsorption, first things first, wherever sodium is reabsorbed on the basal side, you have the activity of the primary active transport, that is the sodium potassium pump. Yes, so this is your primary active transport. You need a primary active transport because sodium is in a very high concentration in the plasma. So on the basolateral membrane, you have the presence of the sodium potassium pump, isn't it? Whenever sodium moves from the cell to the plasma, it is against a concentration gradient, so it needs a sodium potassium ATPase pump. I'm basically trying to discuss with you sodium reabsorption in the thick ascending limb. Maximum sodium absorption, of course, takes place in the PCT, but in the thick ascending limb, why this is important? Because I wanted to discuss a couple of clinical conditions also with you. Now, so primary active transport on the basal side, and on the luminal side, you have a secondary active co-transport, which is called an Na+, K+, 2Cl- co-transport, which is a secondary active transport. A drug which acts on Na plus K plus 2Cl- co-transport, Lasix, right? So the Na plus and K plus and the 2Cl- co-transport. Now the K plus will diffuse out of the cells via what are known as the ROMK channels, renal outer medullary potassium channels. What will happen to chloride? Chloride will leave through what are known as chloride channels. This is chloride channels KB, right? So this is also a passive movement of chloride. Now, sodium is leaving the cell via a primary active transport on the basal side. Potassium diffuses out back into the lumen through the ROMK channels, and you've got chloride channels on the basolateral membrane, which is called the chloride channels KP. Chloride channel is associated with a small protein which is called Bartin. Now, once there is a loss of function mutation of these proteins, gives rise to a condition which is known as Bartter syndrome. So a loss of function mutation of the Na plus K plus 2Cl- co-transport, this gives rise to the type 1 Bartter syndrome. A defect in the ROMK channels will give rise to the type 2 Bartter syndrome. In Bartter syndrome, there is going to be defective reabsorption of sodium, potassium chloride. In type 1, basically there is a defect in the absorption of sodium, and that gives rise to features of hypovolemia. This is type 1 if there is a loss of function mutation of sodium potassium 2Cl- co-transport. Type 2 if there is a defect in ROMK channels. Type 3 is if there is a defect in the chloride channels. Type 4 if there is a defect in the Bartin protein, which is linked with the chloride channel. There is also a type 5 Bartter syndrome which has been recently discovered, and that is because there is a calcium sensing receptor which is present on the basal membrane, and this calcium sensing receptor, this in fact inhibits the Na plus K plus 2Cl- co-transport. So if there is this normally inhibits so if there is a gain of function mutation of this calcium sensing receptor, this is your type 5. This is a gain of function mutation. For type 1, type 2, type 3, type 4, loss of function mutation, then that produces the type 1 to 4 types of Bartter syndrome. Type 5 is because of the calcium sensing receptor. Right. So let's see another favorite topic as far as the INICET is concerned, BER, basal electrical rhythm. What is basal or the basic electrical rhythm? This is generated by what are known as the interstitial cells of Cajal. Interstitial cells of Cajal or Cajal. These are your pacemaker cells of the small intestines. These are responsible for the BER. And what is BER, or the basal or basic electrical rhythm? Now, this is a variation in the membrane potential of the smooth muscle of GI tract. See, the smooth muscle of the membrane potential of the smooth muscle of GI tract is not stable. It varies. It varies between -45 and -65 millivolts. -45 and -65 millivolts. Right? And the amplitude of these waves is 5 to 15 millivolts, and the frequency of these waves is variable in different parts of the GI tract. Please understand, this BER is not responsible for contraction. This is not responsible for contraction. This is simply a variation of the membrane potential. The important point, what is the frequency of BER in different parts of the GI tract? The least frequency is in the cecum, which is 2 per minute. Then you have stomach, which is 4 per minute, sigmoid colon, which is 6 per minute, then distal ileum and jejunum and duodenum. So it is, please remember, the least frequencies in the cecum, which is 2 per minute, and then in the stomach. Maximum frequency is in the duodenum, which is 12 per minute, right? So as far as least frequency is concerned, number 1 will be cecum, then the stomach, and then the sigmoid, and thereafter, but the maximum frequency will be in the duodenum. Is the BER responsible for contraction? No. BER is not responsible for contraction. What is responsible for contraction is the superimposed on the BER. You have the superimposed on the BER. You have the superimposed on the BER. You have the superimposed on the BER, you have these true action potentials, which are also known as the spike potentials. These are what are responsible for the contraction. Remember here, depolarization of the spike potential is due to an influx of calcium. Right? Influx of calcium. Please remember, depolarization in the neuron is because of sodium. In skeletal muscle, because of sodium. In cardiac muscle, it is because of sodium. In pacemaker cells, depolarization is due to calcium. And in smooth muscle cells, it is due to calcium. Flow volume curves, flow volume loops have been asked this time as well. So a very quick revision of the different types of flow volume loops. If this is my normal flow volume loop, you see this is what is seen in obstructive lung disease. Why in obstructive lung disease? Because in obstructive lung disease, the characteristic feature of obstructive lung disease is an increase in the total lung capacity and increase in the residual volume. This is typically seen in obstructive lung disease. And very importantly, if you can make out the shape of the curve is a scooped out curve. This is the shape of the curve is altered from a normal flow volume loop. This is called a scooped out curve, right? So this is obstructive lung disease. The one in blue is the restrictive lung disease. In restrictive lung disease, the total lung capacity has reduced, the residual volume has reduced, the vital capacity has reduced. Vital capacity is the width of the loop, right? So this is typically restrictive lung disease. Restrictive lung disease means restriction in expansion. So all the lung volumes will be reduced. In obstructive lung disease, like I said, increase in total lung capacity, increase in residual volume. But very importantly, the shape itself is abnormal. So this is a typical obstructive and restrictive lung disease. Again, I wanted you to have a look at this is large airway obstruction. In large airway obstruction, fixed type, large airway obstruction, fixed type is due to foreign bodies or due to tumors. This is what is known as a box type of curve, box type of loop, which is seen. Both the inspiratory and expiratory curves are flattened. This is a large airway or an upper airway obstruction. Large or upper airway obstruction, fixed type. Now, upper airways can be extrathoracic, intrathoracic. Extrathoracic above the sixth tracheal ring, intrathoracic below the sixth tracheal ring. Now, this is, if you can see over here expiration is relatively less affected. So this is extrathoracic, upper airway obstruction, variable type. Here expiration is relatively less affected. It is the inspiratory curve which is flattened. Yes, and an example of extrathoracic upper airway obstruction, variable type, like vocal cord paralysis. Yes, fixed type, whether it's extrathoracic or intrathoracic, you will get a similar sort of loops. But extrathoracic variable obstruction, this is the kind of loop that you get. And the one on the right, this is intrathoracic variable obstruction. In intrathoracic variable obstruction, the Inspiration is relatively less affected, expiration is affected more. In extrathoracic variable, expiration is